So in lecture we left off talking about how carbon dioxide is transported around in the body. Again, oxygen is normally transported, the majority of it on hemoglobin molecules. Carbon dioxide is mostly transported around as this bicarbonate ion. So I've taken this because I said again, I'm like, we're going to start here with this equation. Again, very important equation to know for the respiratory system because of this equation it controls several things in the body. And if you have to take advanced A&P, this equation is going to come back up again. Now, we looked at, let me make it larger, some of the little bit differences with the transport and exchange of carbon dioxide. I think we went over a little bit of this that I'm trying to remember exactly where we left off. Oh, yep, we talked about it. I'm like that, yes, and I'm like, if you have lots of this bicarbonate ion, it easily goes into the red blood cells, and I'm like, to get transported around. In pulmonary capillaries, this bicarbonate ion goes in, chloride moves out, and I'm like, just because of the ion difference, and then it will split into the carbon dioxide and the water. And again, it will split, it will go backward and divide into carbon dioxide and water. That carbon dioxide will go into the alveoli. We breathe it out. Now, the amount of carbon dioxide that's transported is affected by how much oxygen there is. So the pressure of oxygen. If you have less oxygen, so it's the reduced hemoglobin, there's not all four oxygen, or not all four heme groups are all holding on to an oxygen. If the red blood cell, if the hemoglobin inside of it isn't picking up as much oxygen, it can also pick up carbon dioxide. Again, not all carbon dioxide is moved around or transported in the body as bicarbonate. Some of it is picked up by the hemoglobin. And just because hemoglobin can pick up and transport oxygen, and it can pick up and transport carbon dioxide, it allows our body to be as efficient as possible. As it starts to unload oxygen, and I'm like, we have the reduced, it will pick up carbon dioxide. And I'm like, this allows a really efficient exchange at tissues and in the lungs of picking up and dropping off. Now, the carbonic acid bicarbonate buffer system. Again, the carbonic acid, here's your carbonic acid, bicarbonate buffer system. Because of this hydrogen ion that we have right here, and because this equation can go back and forth, I'm like, this allows our body and our respiratory system to be able to control our body's pH. Example, if we start to have excessive amounts of carbon dioxide, it will mix with water, it will make carbonic acid, and it'll eventually release hydrogen ions. This excessive hydrogen ions, lots of hydrogen ions, and I'm like, means it's acidic, it has a low pH. We don't want acidic blood, so we need to get rid of the hydrogen ions. And so what it will do, and I'm like, if the if the hydrogen ion becomes too excessive, we can remove it. We can make this equation go back to the left. We can take some of our bicarbonate ions, mix it or pick up some of those hydrogen ions, turn them into the carbonic acid, and I'm like, so we've got our carbonic acid. Now we have less hydrogen ions, we have less acidity, meaning we are now becoming more basic. And the exact opposite, if the hydrogen ion concentration begins to drop, there's not as many of these, we're becoming too basic, we're getting above that 7.45 on the pH scale, means we want more of these. So we're going to take that carbonic acid, we're going to break it apart, dissociate it, and we're going to release that hydrogen ion. And I'm like, lowering that pH. If it gets again above that 7.45, we want to lower it and try to get into that 7.35 to 7.45 range. So the fact we can go back and forth in this equation allows us to keep our pH at, as that tiny little range as much as possible. And because we also know that breathing, because we can go back and forth on this equation, affects pH, I'm like, changes in respiration rate and depth affect our blood pH. Just the example, I'm like, slow, shallow breathing increases how much carbon dioxide we have in the blood. It's going to drop your pH. The more carbon dioxide, the more hydrogen ions will be released. Hydrogen, this means it's going to be an acid, it's a low pH, so your pH drops. Right? Vice versa, if you have rapid, deep breathing, you're going to have less carbon dioxide in your blood, and I'm like, you're going to have less hydrogen ions, and you're going to have a rise in pH. So if our pH changes, in our blood, we can actually change our ventilation to try to adjust our blood pH. Now, on to things that can control our respiration. So, and a lot of it, our nervous system, our brain, reflexes, various receptors, are going to control our respiration. Now, in our nervous system, the two big nervous system parts that control our respiration is the medulla, or the medulla oblongata, and the pons. Now, in the medulla, there are two little areas in our medulla. And if you remember, the medulla is really important because if you damage it, you die. Because one of the things it controls is breathing. And now, in the medulla, there's two little parts. There's a ventral respiratory group and a dorsal respiratory group. I'll go back to that slide. This is just showing, here's your medulla, here's the front of the body, here's the back. So here's your ventral respiratory group and your dorsal respiratory group in the back. Now, the ventral respiratory group, the one in the front, and I'm like, it is the rhythm generating and integrative center. It's kind of like the boss between the two. It sets our normal respiration rate and rhythm, meaning I'm like, we are taking consistent breaths and approximately 12 to 15 breaths per minute. That's set by that ventral respiratory group. Now, the way it does it, how it controls our respiration, is that the neurons excite our inspiratory muscles, our diaphragm, our external intercostals, and I'm like, it's telling them to contract so that we increase the volume, decrease pressure, air goes in. Now, the interesting part is that we can suppress the ventral respiratory group, which isn't good. Ventral respiratory group makes us breathe. You can completely suppress it if you overdose on morphine or if you overdose on alcohol. And I'm like, it will shut down our ventral respiratory group. This is why a lot of people die from overdosing on morphine and alcohol, is the ventral respiratory group is no longer telling their diaphragm and their external intercostal muscles to contract, and you're just going to stop breathing. The dorsal respiratory group, the one at the back, and I'm like, it receives information from our peripheral state, and I'm like, so different parts of like the outside of the body, including part of the lungs as the lungs are stretching, as well as some chemoreceptors found in various blood vessels that are detecting chemicals like pH and carbon dioxide levels, and it's just going to send information to the ventral respiratory group. So it's, picking up information, and then it just tells it to the ventral respiratory group, and then be like, all right, you do something about it. I'm just receiving information. The pons, it's called the Pontine respiratory group, and I'm like, it's the pons, and I'm like, it just smooths out the transitions between inspiration and expiration and vice versa. And so that we have nice, clear breathing in, breathing out, there's no stopping, there's no gasping. And so it sends information to that ventral respiratory group, and it allows us to also modify some of our breathing. It depends. If you're talking, your breathing has to change. I'm like, or singing too, and I'm like, you're not breathing all normal. When you're sleeping, it's relaxing. When you're exercising, it's speeding up. And so the pons kind of, the ventral respiratory group sets our rhythm. The pons kind of modifies it based on what we need. Then there are chemical factors that are going to control respiration. I'm like, biggest chemical factors, carbon dioxide and oxygen. Now, carbon dioxide is the most potent, so it's the most powerful influence on our breathing rate. So it's the most closely controlled. If our blood carbon dioxide levels rise, this carbon dioxide will accumulate on the brain, which isn't good. Reason for it, the carbon dioxide in the brain starts to become hydrated, and I'm like, or I shouldn't say, carbon dioxide in the brain, which is hydrated, forms carbonic acid. So if you have excessive carbon dioxide accumulating near the brain, and then there's water there, the two will mix together. It will make carbonic acid, and then it will break down, releasing hydrogen ions, which means now we are lowering the pH around our brain. That's never good either. Now, when this starts to happen, so if you start to have too much carbon dioxide in your body, and I'm like, and you're making these additional hydrogen ions near your brain, we have chemoreceptors on our brainstem. Again, these are receptors that are detecting chemicals such as a hydrogen ion. And these chemoreceptors will be like, look, there's way too much hydrogen ions. And they're going to work with the respiratory system. They're going to change your breathing. You're going to increase the depth, increase the rate, and we're going to try to lower our carbon dioxide levels, getting that pH to rise again. And so I'm like, we want to try to sit there and get rid of some of the carbon dioxide by increasing your depth and rate of breathing. So your carbon dioxide levels ultimately, I'm like, they change the pH in your body, and then you specifically around your brain as well, and then your brain's like, oh, don't like this, let's change our breathing, and we try to regulate that carbon dioxide. Now, hyperventilation, if you've heard people hyperventilating before, it just means you have an increased depth and rate of breathing that exceeds the body's need to remove carbon dioxide. You've breathed out too much carbon dioxide, so you have a decreased blood carbon dioxide level, which can lead to dizziness and fainting. So people that are hyperventilating, they're losing too much carbon dioxide, can cause dizziness and fainting. Occasionally, if you have low enough carbon dioxide levels, it can actually cause you to stop breathing. It's called apnea. The A at the beginning of anything means without. Pnea means breathing. So apnea is without breathing. Now, that usually can happen. It's usually not enough to cause death, but you stop breathing, and eventually, as you stop breathing, the carbon dioxide levels will rise again because you're not breathing any carbon dioxide out, and then it will stimulate back to breathing again. So it's almost like a fix, but it can be kind of a scary fix. Then, and I'm like, yes, one of the chemicals that can influence breathing is oxygen, because most people are like, oh, well, it's oxygen that's totally influencing how much I'm breathing. It does have a little influence. We do have receptors, chemoreceptors, again, receptors that detect chemicals such as oxygen in our aortic and our carotid bodies. So these are in your aorta and your carotid arteries that are detecting your oxygen levels. Now, when excited, when these chemoreceptors are detecting lower oxygen levels, and I'm like, they can cause your respiratory center to increase your ventilation. However, declining oxygen levels normally, I was going to say, have a slight effect on ventilation. If you don't have as much oxygen in your blood, it's not usually going to trigger a lot of breathing. Carbon dioxide is really what's triggering breathing. Oxygen levels, and I'm like, don't trigger it a lot. Main reason, I'm like, we have a huge oxygen reservoir attached to all those hemoglobins. If you remember, 98% of our hemoglobins are fully, full of oxygen. So it requires a substantial drop in our arterial oxygen levels to stimulate increased ventilation. And I'm like, substantial drop goes all the way down to 60 millimeters of mercury versus the normal 100 millimeters of mercury. I'm like, so you need a big drop in oxygen levels to start triggering our breathing or affect our breathing rates. Another chemical that can affect breathing rates is the pH. And again, we've already kind of talked about it. Yes, pH can change your respiratory rate and rhythm even if your carbon dioxide and oxygen levels are normal. Occasionally, your pH may be changing not because of carbon dioxide levels or oxygen levels. Your pH may reflect, and I'm like, yes, some carbon dioxide retention, or lactic acid. You just got done working out and now you have all this lactic acid. You've just changed the pH. And I'm like, you can get ketone bodies, which can change the pH. Usually this only affects ketone bodies is people that have diabetes and it's going uncontrolled. Your pH can increase. I'm like, that's usually the people, I'm like, the only time that usually happens. But, and I'm like, either way, doesn't matter how the pH changes, we can change our breathing rate based on it. And so we can try to control that pH by increasing our respiratory rate and the depth of your breathing. So my little summary of the chemical factors. So there's really 3 chemical factors: carbon dioxide, oxygen, and pH that are going to affect your breathing rate. Carbon dioxide level is the most powerful stimulant of our breathing. It's only if oxygen levels have that severe drop in oxygen levels down to 60 versus 100 millimeters of mercury before it really affects respiration. And any change in pH, whether it's from carbon dioxide or some other metabolic factor, can also change our respiration rate. Now, some higher brain centers. So it's not just the pons and it's not just the medulla. We do have our hypothalamus that can change breathing as well. A little bit through our limbic system. And if you remember what the limbic system controls, it's our emotional state. And you're like, well, how does emotional state affect breathing? Well, an example, I'm like, if you're really angry, that may cause you to hold your breath. Or if you're in pain, you may gasp. And I'm like, so there are certain emotions that can change your breathing. I'm like, if you're really mad, you may start, to start breathing harder and deeper. Also, other things, I'm like, a rise in your body temperature can increase your respiratory rate. And I'm like, whether it's you're working out or something like that, my little example, I'm like, yes, body temperature increases your respiratory rate. Usually it is because you're working out, so it's a natural, I'm going to say the natural order is we need more oxygen. But if you do a reverse, if you've ever done something like the polar plunge and you jumped into ice cold water, and I'm like, the opposite, it will decrease your respiration rate. A lot of times you stop breathing or you gasp for breath because of that cold, that quick decrease in temperature. Then you have your cerebral motor cortex. This is really our conscious thinking, our outer part of the brain. We can bypass our medullary controls, meaning if you want, you can stop breathing. You can hold your breath. Some of you have all hold your breath at some point, whether it's your diving, swimming, whatever, or you think it's fun when you try to hold your breath with your friends. I'm like, you hold your breath for as long as you possibly can, but however, at some point, your carbon dioxide levels are going to get high enough that your brainstem is going to reinstate your breathing. You can't hold your breath forever. I'm like, at some point, your brain's like, oh, we need to start breathing now. Carbon dioxide levels are too high. Some other things that can influence air going in and out are some irritant reflexes. We've got receptors in our bronchi, or our bronchioles, that can respond to any type of irritants. They just promote, reflexive constriction of air passage. If you've got some type of dust or something that are getting into your bronchioles, we don't want it there. And I'm like, so we're going to try to constrict those so we don't get those irritants in. Now, those same irritants, before it get to the bronchioles, can also cause, if it's in the trachea, it can cause you to cough. Or if it's in those primary or secondary bronchi, it can cause you to cough. Or if you have some of those same irritants in your nasal cavity, it can cause you to sneeze. And so there are a couple different things that just affect your air going in and out. And a lot of it's something's irritating. So whether you're coughing or sneezing or trying to constrict those airways to try to prevent that irritant from getting in, it's all things that are affecting breathing. Then we have another reflex to talk about. It's called the inflation reflex. Now, yes, I like to just call it the inflation reflex. It's officially called the Herring-Brewer reflex. Because of course, if you're going to develop or, be a scientist, you're going to name something after yourself. It just means that when your pleura, and I'm like, that is, we've got the pleural sacs, and I'm like, holding those lungs, when they start to stretch, and they, and the airways are all stimulated because your lungs are inflating, we don't want to inflate our lungs too much. So as we're starting to receive all this information that our lungs are stretching larger and larger, we start to have inhibitory signals that go to our medulla to end inhalation and allow us to breathe out. And I'm like, it acts as a protective response. It just tries to prevent our lungs from overstretching, from trying to fill up too much, causing damage. Now, some adjustments to our breathing, and the big one is, is exercise. That yes, we can increase our ventilation rate 10 to 20 fold in response to metabolic needs. We need more oxygen if our muscles are exercising. However, during exercise, because we can adjust everything, carbon dioxide levels, oxygen levels, and pH usually still remain pretty constant with our breathing. Now, there's 3 factors that can, when it comes to exercise, that can increase your ventilation as your exercise begins. The first one actually happens before you even start exercising. It's a psychological stimuli. It's an anticipation of the exercise. So you're getting all your exercise clothes on, or you're driving to the gym, or you're just, like, all right, I'm going to do this. As you're thinking about exercising, you already start to increase your breathing rate without even exercising yet. It's a psychological, it's like you're anticipating the fact that you're going to need more oxygen. So before you even start exercising, yes, you're going to have a change in your breathing. Then you actually have the second part, the skeletal muscles, and you are starting to be stimulated. We're sending information to the skeletal muscles that they need to start working, as well as the respiratory centers that we need to start contracting more. That's going to change your breathing rate. And then finally, the fact that you have moving muscles, moving tendons, and moving joints, there are receptors there that are saying, okay, we're actually doing something. We truly now need oxygen. And I'm like, let's get oxygen in, let's get carbon dioxide out. Now, problem happens as soon as you're done with your exercising, you just got done running a mile or whatever it is, most people just want to fall over and lay on the floor or lay on the ground. However, ventilation declines suddenly as exercise ends. Because as soon as, you stop running, as soon as those muscles stop moving, and I'm like, right away, your breathing rate slows down. But you still need lots of oxygen, so it's kind of one of those, and I'm like, even though you're done with your exercising, still move around a little bit, still get those muscles moving, so that our breathing rate is realizing like, hey, well, we're not running, but we are still moving, so we still need to increase that respiration to get that oxygen in and the carbon dioxide out. How, later, and I'm like, you're going to have a gradual decline, your breathing will slow down, you're not going to have as much carbon dioxide being produced after your exercise is done, and you'll slow down your breathing. Now, exercise, yes, can lead exercise can lead to anaerobic respiration when you can't get enough oxygen. Now, that can happen, and it will lead to lactic acid. That doesn't mean you have a poor respiratory function. And your lungs were doing everything they possibly could, and they were providing enough oxygen. It's usually some type of cardiovascular, you have a weak or poor cardiovascular system because you haven't worked out in a long time, or your skeletal muscles can't increase their oxygen uptake. And I'm like, you don't have enough mitochondria, and I'm like, to make ATP using the oxygen that's there. I'm like, you're just not getting enough oxygen. The cardiovascular system's not bringing the oxygen to the muscles that it needs. So it's not a respiratory function, and I'm like, it's usually a cardiovascular or skeletal function. Now, some other adjustments other than exercise, and I'm like, is high altitude. If you have ever traveled somewhere to high altitude, you've gone somewhere out to Colorado or Utah or somewhere into a mountain somewhere. If, as you're driving up and you're not really stopping anywhere, and so you have this quick travel to an altitude, you may develop symptoms of, it's called acute mountain sickness. It's altitude sickness. A lot of it's because your oxygen level, the pressure of the oxygen levels and your oxygen levels start to lower. It can lead to headaches, shortness of breath, nausea, dizziness. Only in severe cases, you can have lethal cerebral and pulmonary edema. And I'm like, that for some reason you're not getting oxygen to, yes, your heart and your brain and your lungs, and you start to have fluid buildup. That's rare. And that's in severe cases, and usually have some type of respiratory or cardiovascular problem to begin with. But most of you will probably experience at least the shortness of breath going to these high altitudes. However, if you stay at the high altitudes long enough, you do become acclimated. And so your respiratory system is going to start to compensate for this high altitude and low oxygen. Your blood, you have hemopoietic adjustments. And I'm like, as well when you have high altitudes. Now, and I'm like, for the respiratory adjustments, yes, your chemoreceptors, these little receptors detecting chemicals, are going to be more responsive to your carbon dioxide levels. And so instead of having just a large change in carbon dioxide levels, although it's never really large, to change your breathing, minor amounts of carbon dioxide level changes can change your breathing rates. And usually, and I'm like, within a few days, your minute ventilation rate increases. And so how much air is getting into your respiration, or into your respiratory system, into your lungs per minute, it's the minute ventilation, and I'm like, will start to increase. And I'm like, so within a couple days, you're starting to breathe about 2 to 3 liters of air per minute, more in a higher altitude than when you are at sea level. Now, you're always going to have lower than normal hemoglobin saturation levels at higher altitudes. There's less oxygen there. And so instead of having 98% of all your hemoglobin fully, all full, you might have closer to about 67% of your hemoglobin full. It's still enough though. And so I'm like, that's still absolutely enough oxygen to survive. Otherwise people would never live at high altitudes. However, what will happen is you start to have less blood oxygen. It will stimulate your kidneys to accelerate the production of that erythropoietin. It is the hormone that stimulates the making of red blood cells. And so you're going to start to have more red blood cells to carry the small amount of oxygen that is there. And so you're going to have this kind of long-term compensation. If there's less oxygen, but now we have more red blood cells to carry the oxygen that there is. If you've ever, I was going to say, and if you live at a higher elevation for a while, and if you're a person that donates blood, your blood at a higher elevation is actually darker. You have more red blood cells. It's actually a darker appearance than if you were at sea level, just because it has more red blood cells in the blood. Now, away from, we can change our breathing, into some homeostatic imbalances, aka problems. The first problem with respiratory system is our COPD. You've probably heard commercials. There seems to be lots of drugs out there, but it stands for chronic obstructive pulmonary disease. Now, and I'm like, it in itself, and I'm like, it's a disease, it's a disorder, it's usually caused by other disorders. So usually kind of the other disorders that work together that cause chronic obstructive pulmonary disease, chronic bronchitis, which we'll talk about, and emphysema, which we'll talk about. But the obstructive part becomes, it's an irreversible decrease in the ability to force out air out of the lungs. You can't move air out. You can't get that carbon dioxide out. And if you can't get all that air out, you also can't get all the air in to get the oxygen. So since you can't force it out, that's the obstructive part of the chronic obstructive pulmonary disease. Now, some common features. Most of the people that have it, about 80%, usually have some type of history of smoking. They usually have very labored breathing because they're air hungry. They're constantly trying to get enough oxygen into their body. They usually have lots of coughing, frequent pulmonary infections, and eventually, and I'm like, it can develop into respiratory failure. It's called hypoventilation, and I'm like, they cannot breathe enough, and I'm like, they can't get the oxygen in, but they definitely can't get that carbon dioxide out, which is going to affect blood pH. And so it can lead to respiratory acidosis and hypoxemia, not enough oxygen in your blood. Now, one of the things that, yes, can lead to COPD is emphysema. Emphysema, I tried to draw this on the board with my little circles, and I'm like, it's destruction of your alveoli. Again, your alveoli is where you have the greatest amount of gas exchange taking place. And I'm like, to get from the alveoli, I'm like, from the lungs into your blood supply. So, and the more surface area you have on the alveoli, the more gas exchange. Well, this destroys those alveolar walls, leading to less surface area, less gas exchange. It can also lead to decrease in lung elasticity. And I'm like, anytime you're destroying anything, it can lead to scar tissue. And I'm like, which it's not going to be elastic. You can't stretch your lungs out as well. And so people that suffer from emphysema, just to be able to get air in, have to start using accessory muscles other than just the diaphragm and your intercostals. And so I'm like, if you have to start using this accessory muscles all the time just to get oxygen in, a lot of times they are just exhausted all the time. And I'm like, it's almost a workout every day just to breathe. And then there's the chronic bronchitis. Again, the word itself means an inflammation of your bronchi. Usually it's due to some type of inhaled irritant. I'm like, that's what starts it all off. Yes, a lot of times it's smoking. It can cause chronic excessive mucus. Now, this excessive mucus in your bronchial tubes will inflame your mucosae. And I'm like, all of those membranes inside your respiratory tract, they start to become fibrosed. And I'm like, and your lower respiratory passages no longer can expand, they no longer can receive as much air anymore, and you start to get obstructed airways. Now, obstructed airways, well, yes, impaired lung ventilation, air in and out. No less air in and out, less gas exchange. And because you have this excessive mucus, you're usually going to have excessive or frequent pulmonary infections. Anytime you've got a nice, thick fluid like mucus, and it's in the respiratory system where it's nice and warm, bacteria love nice, warm, moist areas, and you're going to end up having excessive or more frequent pulmonary infections. Now, with COPD, some basic symptoms and treatment. It varies with patients. There's kind of two groups of individuals that have COPD, and it all is based on their innate respiratory drive. Innate meaning, things you're born with, things you don't have to think about. And so you have different symptoms. Usually we consider, or we call the two different groups pink puffers or blue bloaters. Now, if you are a pink puffer, usually I'm like, you're gonna be a very thin individual. Reason why, their natural, their inborn response is to constantly be working really hard to breathe. They're using all those accessory muscles. Again, they're getting a workout every time they breathe. So they're very, very thin. And because they're working so hard to get that oxygen in, they usually have near normal blood gases. They're just exhausted. Now, the blue bloaters. This usually happens, and I'm like, where you're not using all those accessory muscles, and you usually have more of a stockier build. Now, because they're not using all those accessory muscles, they usually have a stockier build. They're usually a little bit bigger. They're not getting all the oxygen they need, and so they become hypoxic, which just means less oxygen, which it can cause them to be cyanotic, turning a little blue. And so the bloater is because they're a little stockier, and the hypoxic is because you're going to start to turn blue. You're just not getting all the oxygen you need. Now, how they can treat it, they can treat it with bronchodilators to try to open up those airways, corticosteroids, use some type of inhaler, try to give them additional oxygen, and then sometimes they'll even do surgery. They'll try to remove damaged lung tissue so the remaining lung can expand. Like if there's some healthy lung, it can expand as big as it possibly can. This is just showing, how people generally get COPD. The top way people get COPD is tobacco smoke, as well as air pollution. So people that live in really large cities where there's lots of air pollution, New York City, places in China and Japan, and I'm like, that yes, can eventually get chronic bronchitis or emphysema, and I'm like, causing the COPD. On occasion, and I'm like, emphysema can also be caused by a genetic disorder as well. It's just a deficiency that starts to break down your lung tissue. That's rare, but yes, there is some people that have never smoked before still have emphysema. It's genetic. Another homeostatic imbalance, another disorder, asthma. It's reversible COPD. So it's like all the COPD things, but it can go away. And I'm like, a lot of characteristics of asthma: coughing, difficult breathing, wheezing, chest tightness. For those of you who have suffered from asthma, you're like, yep, I get it all. And yes, and I'm like, the first thing that's going to happen is you're going to inflame the airways, and I'm like, which will lead to bronchospasms. And I'm like, that usually that's the coughing part, it's spasming, and I'm like, because of this inflammation, which it usually is also constricted, so you're not getting that air out and you're not getting the air in. Now, this airway inflammation is usually some type of immune response. Your immune system is allergic to something, it's triggered by something that is causing that inflammation. And so you're usually given some type of inhaler, which is going to have some type of epinephrine or steroid to try to dilate those bronchial tubes and try to get them open again. Another disorder is tuberculosis. It's caused by a bacterium called Mycobacterium tuberculosis. And I'm like, and yes, we nickname it TB. Anyone that works in the healthcare all has to get tested for it. Symptoms of having tuberculosis: fever, night sweats, weight loss, cough, and definitely coughing up blood. Now, this bacterium is hard to treat. And I'm like, it doesn't like to go away quickly. And so people that have this bacteria have a 12-month course of antibiotics. And so instead of just being like, 2 weeks, 14 days of antibiotics, you're on antibiotics for a year. And right now they're also starting to develop, some of these Mycobacterium tuberculosis are starting to get resistant to some of the antibiotics we have on the market as well. Another disease is lung cancer, leading cause of all cancer deaths in North America, and 90% is all because of smoking. So it is a preventable cancer. Now, early detection is key. If it hasn't spread, if it hasn't metastasized, if it's not spreading to different parts of the body, they just remove the diseased lung tissue. Again, you could remove a whole lobe, you can remove a bronchopulmonary segment just fine. If it has started to spread, they're going to do radiation, they're going to do chemotherapy. However, by the time it starts to spread from the lungs, it usually starts to spread everywhere in the body, and it's not as successful. So really, you need to get it treated as early as possible before it starts to spread. Now, some developmental aspects. And I have one more. And I'm like, cystic fibrosis. Most common lethal genetic disease in North America. It's a respiratory disease. Yes, it can kill, but it's also genetic, so it doesn't have anything to do with smoking or breathing. What happens is like you have abnormal viscous mucus that clogs your passageways. And again, as I said before, and I'm like, if you have mucus built in your respiratory system, it's warm, moist environment. Bacteria love it. Now, the reason you end up getting this thick mucus in your respiratory system is that people that have a cystic fibrosis have an abnormal gene for your chloride membrane channel, which, if there is less chloride secreted, less water follows, and I'm like, and you're going to have thick mucus. Normally you should have chloride going into where that mucus is, water following it, and you have a thinner mucus. Now we don't have that, and you have really thick mucus that's really hard to clear. Now, people that do treatment, and I'm like, or treatments for it, they try to give mucus dissolving drugs. They try to do manipulations. It's almost like shaking the body to try to loosen the mucus that's in the respiratory system. And they're on antibiotics all the time to try to prevent all of those respiratory bacterial infections. Now, onto my developmental aspects. First, upper respiratory structures are the first thing to develop before the lower ones. And so your nose, your nasal cavities, we can already start to see these little olfactory pits. And I'm like starting to develop by the 4th week. I've got a picture in a minute. And we also start to get the laryngotracheal bud that's going to split into become the larynx and the trachea by the 5th week. And I'm like, before you even know you're pregnant, you're already that baby is already starting to get respiratory organs. Now, by the 8th week, you're going to start to develop mucosa of the bronchi. You're going to start to get lung alveoli. I'm like, all of these, again, by 8 weeks. And so here's looking at 4 weeks and 5 weeks. So 4 weeks, and I'm like, it doesn't look like much, and it looks really weird. But yes, there are olfactory placodes. These are going to be the nasal passageway. You're like, it looks like some weird alien thing. Yep, but by 4 weeks, this will become the nose. By 5th weeks, we start to get, here's our little trachea, bronchi, pulmonary, or bronchial buds. So right away, you're already going to start to get to, little division when you're going to start to get lungs forming off of there. By the 28th week, a premature baby can breathe on its own. And again, if you remember what's so important about the 28th week, this is when you start to make that surfactant that can reduce the surface tension so that lungs can expand and we don't have lung collapse. Now, during fetal life, because they are not breathing air, the lungs are filled with fluid, and all the blood just bypasses the lungs. It's pointless. The blood doesn't go to the lungs to get oxygen. All gas exchange takes place, via the placenta. Now, what does happen after that baby is born and there is now air surrounding the baby, respiratory passageways, trachea, nasal cavities start to fill with air, and all of a sudden carbon dioxide is now in the body. Just having that initial carbon dioxide getting in the body, then I'm like, you have an increase in carbon dioxide. Increasing carbon dioxide is one of the most powerful things that changes breathing. That little bit of carbon dioxide now in the body that caused that rise is going to make that baby take that first breath. And I'm like, it's going to start that respiration, of getting air into the lungs. So it all had to do with carbon dioxide that made you take that first breath. Now, yes, they will then start to continue to breathe, but it takes about 2 full weeks before the lungs are really all inflated. And I'm like, really getting air into all of those alveoli. Now, I think I already said some of this, that yes, I'm like, takes 2 weeks, blah, blah, blah. Interesting part, respiratory rate is really high in newborns. And I'm like, newborns can easily take 40 to 80 breaths per minute. And I'm like, it just seems like they're breathing really, really fast. It's like every second they're taking a breath. Adults, we take about 12 to 18 breaths per minute. That's what our medulla set as our breathing rate. Newborns, breathing, 40 to 80 breaths per minute. Now, yes, the lungs will continue to mature. We'll start to get more alveoli, and I'm like, until about young adulthood. Obviously, your lungs are larger as an adult than when they were when you were, a 6-pound, 7-pound baby. And so the lungs will grow. You'll develop more alveoli. Now, the aging sucks. I know it only has one bullet point, but my aging sucks, and this is why your respiratory efficiency decreases as you get older. Here are some things that, yes, why your respiratory efficiency decreases. 1, your respiratory volume decreases. You cannot expand your respiratory cage as large as it as you can, or you can't expand it as large then as you can now. Your thoracic wall starts to become more rigid. everything starts to stiffen up. Again, you can't increase that volume if the thoracic wall is starting to become more rigid. The lungs lose some of their elasticity, so when they stretch open, they don't recoil as quickly as they should. And your blood oxygen levels are going to start to decline, which for some it can actually lead to sleep apnea. And so if you know anyone that suffered from sleep apnea, it's something that developed as usually as they got older, not always as when they were a kid. Some kids have it, but it's usually as you get older, it's your respiratory's on the decline. It has to do with your blood oxygen levels. All right, finally, on to the review questions. I'm going to try to go through these a little faster. So even the most forceful exhalation leaves air in the lungs. This is called, like, the residual volume, and is needed to keep your alveoli patent or open. And I'm like, so you don't have lung collapse. The two gases that contribute to 99% of your total atmospheric pressure, nitrogen and oxygen. Two big things. When I did the math on the board, those were the two I looked at. The pressure that's exerted by each gas in a mixture is proportional to its percentage. Again, here's the laws. That's Dalton's law. Talks about the different pressure percentages. Hemoglobin molecules are fully saturated when they are bound to 4 molecules of oxygen. Red blood cells contain the enzyme carbonic anhydrase, which is the enzyme that forms carbonic acid. This, and I'm like, the ventral respiratory group is responsible, it's found in the medulla, is responsible for setting your basic rhythm of breathing at 12 to 18 breaths per minute. The most potent or powerful chemical that influences respiration, I hope you get it, carbon dioxide is the most important chemical that influences respiration. This is produced by the what in response to low oxygen levels? Erythropoietin. It is the hormone produced by the kidneys. Most people don't think kidneys have anything to do with the cardiovascular system. They do, because they provide the hormone that says we need more red blood cells. And then finally, the loss of lung elasticity and the destruction of alveolar walls is termed emphysema. So you're losing that surface area.